Charlotte Milns, thanks so much for talking to us. You are a senior specialist breast care nurse at the Wythenshawe Hospital in Manchester. And I know what my breast care nurses have done for me, continue to do for me, but I'm really interested at the start of our conversation to just ask what your view is of your role. What is it that you bring to your patients and within your department?
So I suppose, it depends on where you have your treatment. In my department, patients are given a named nurse. So where you're sort of, you're one-to-one, so to speak, through treatment. You should meet your nurse pretty early on. We are there when you have your diagnosis. The appointment is generally run by the consultant, but then you should have an opportunity to meet with your breast care nurse after that appointment, to go through things again, ask questions, and the nurse will give you, sort of tailored information specific to you, to your situation, but ultimately offer emotional support at that point. But we're there throughout all stages of your treatment. It's not just the beginning, it's not just the end. There's guidance that we offer throughout. We help with decision making, because it can be really daunting. You're sometimes offered options that you don't know where to turn. So we talk through surgical options with you. We talk through reconstructive options if that's on the cards. We often meet with our ladies face to face and give sort of more in-depth information, show pictures, and just take as long as it takes to get you to that point of where you've reached the right thing for you, but it's a holistic approach. It's not just a physical thing, it's an emotional thing, of course. And it's looking at all aspects of how life can be turned upside down. So whether that be, financial, ladies may need financial advice, or looking at work or employment, or actually just knowing what's available out there in terms of benefits. We're able to tap into those things and offer that support. We are just one person, but we work as part of a big multidisciplinary team. So we are there as your sort of go-to to coordinate your care.
And is it important that you and others in your team are, goodness, you can't be there 24/7. I'm sure your patients would love you to be, but yeah. We all think back to our own diagnosis, and my nurse was fantastic after the consultant gave me the news, and then she took me to another room and explained certain things. But you go home and sort of 48 hours later, you think of 20 questions you wish you'd asked her, because you're still absorbing all the information. And I suppose is the point that you are also there at the end of a phone as much as you can be, to ask all those follow-ups, and that travels through the years, really.
Yeah, absolutely. We can't expect any human being after just been blown a diagnosis to know exactly what to ask, when you're put in that situation. And it could be that things become more relevant as you progress through your treatment as well, and things come to light, and we're there really to respond to those needs, to draw upon all the services that we work with, to make sure that we're meeting all of those needs that people need, really. So yeah, we are on the end of the phone most of the time.
And I'm fascinated by what training are you given about the difference between ductal and lobular, the very reason this charity exists. How much talk is there of the difference between them, and those differences in information? How much should you pass on to the patient?
Yeah, I spoke to some of my colleagues about this, and I think obviously personal and professional development is different for every nurse. And I suppose it's what you have exposure and access to in terms of education. There is a postgraduate course called the Principles and Practices of Breast Care Nursing, which often does talk about the differences of different breast cancers, albeit it sort of varies on a year-to-year basis in terms of the content. But I think a lot of it is what you pick up during your everyday to-day practice, and the experience that you gain as a nurse. And when you become more senior, you sort of build on that experience through discussions with other colleagues, through cases that come to light, through patients as well. Patients can be great, forms of education to you. I think in terms of when we mention differences, for me, it's very much at the beginning of diagnosis. I talk about how lobular breast cancers can be more difficult to measure on standard imaging. They can be more sneaky in terms of they tend to present themselves in a more linear type fashion rather than an actual lump as such. And so all patients should be offered a pre-treatment MRI scan. And that's to allow us to make sure we know exactly what we're dealing with. So I sort of like to prepare my patients for the fact that this MRI scan can throw up things that we weren't aware of, can throw up things in the other breast, it can throw up multiple areas in the diagnosed breast, but it can also show a larger extensive disease than what we thought we were dealing with. And so it's managing those expectations, but also managing what potentially could be thrown up from that in terms of extra investigations, which can increase timeframes to treatment, which can be tricky. So we like to try and manage those worries really from
And where are we with the regular use of MRIs? Because lots of women watching this video will know that there are lobular cancers, because of the way they grow, as you've described, they don't necessarily show up on a mammogram. I'm not trying to frighten people. It's not always the case, of course, but my own case, it was a very big tumor, but it still didn't show up on a mammogram. It took an MRI. I feel really lucky. I was told from the get-go that throughout my 5 years where I'm being looked after, I will have an MRI every year for that reason. But over the years I've been treated, I've discovered that that's not the case for every woman. So where are we with that debate, and what are women discovering about whether they are or are not entitled to an MRI?
So I spoke to one of my radiology colleagues about this, who are a little bit more in the know than me. We currently don't have any specific guidelines in terms of MRI surveillance and lobular breast cancers. We do offer the preoperative or pre-treatment MRI, so all patients should be getting that at point of diagnosis. But we very much assess things on an individual basis. At the moment, mammograms are the gold standard for surveillance. However, discussions should be taking place between your team at the end of your treatment, or once we've gotten your surgical histology and we're planning your follow-up plan around whether your breast cancer was seen at all on mammogram. And if not, if it was what we call mammographically occult, then really you should be being offered MRI along with the standard mammographic surveillance. But I think there's a grey area, and we very much say, we should be looking at individual people and individual cases. If you do feel that you're not getting follow-up correctly, then I would say go and speak to your clinical team.
And when you say mammographically occult, that means it didn't show up on a mammogram. There's something there, but it didn't show on a mammogram.
Yeah, not seen on the mammogram. Obviously, we can pick up lobular breast cancer through other means, whether it be you feel it yourself or it can be seen on ultrasound. But yeah, so in terms of actual surveillance using a mammogram, it hasn't been seen. We do often team it with MRI because it's more sensitive.
Okay, we've had so many questions for you, I know, to the charity, questions for someone with your specialism. I want to just go to the one that comes up most often, not surprisingly, and it's about the drugs, tamoxifen, letrozole, and others. I'm imagining that's one of the key things that you, in your job, get asked about by women. Again, just talk us through the advice you give. What sort of training is there on that? Because we know that the tablets affects everyone differently.
Yeah, we have a lot of training on it, and it is probably one of the biggest things that comes about. And it's so unfair, really, because we get you through treatment and you're relatively quite well, and then we on the tablets, and that's it. The world comes crashing.
Then you suddenly feel about 95 when you wake up in the morning.
Yes, I mean, I'd say not everybody experiences all the side effects. Some experience, a few, but some ladies really, really do struggle. What I would say is what we like to advise, try and stay on them for at least 3 months, because symptoms can plateau off after that 3-month stage. Joint aches, which is a big one with what we call aromatase inhibitors, or your letrozole, anastrozole, exemestane, they can reach a peak at 6 months, but then start to ease. So I would just bear that in mind when you do start on your tablets. Just try and be a little patient and see how you go on them. But menopausal symptoms are the big one, really. That can really affect quality of life, particularly, your hot flushes and your, night sweats and things like that. So we bring it back down to basics. We talk about the easiest things that you can do in terms of make changes. So wear layers. If you're having a hot flush, it's easy to take a layer off rather than be stuck with you've only got one layer on. And I know that sounds so basic, but it can be really effective when you need it. There are things such as making sure you're keeping your caffeine and your alcohol intake down, because this will exacerbate those hot flushes if you're having, a high intake of either caffeinated drinks or alcohol. Some ladies like to try herbal supplements. So I would be careful with things that contain phytoestrogens, because these mimic estrogen activity and we want to stay away from that. But high-dose sage or high-dose evening primrose oil or starflower oil that can be purchased over the counter can be really effective. Again, I'd say give them 3 months, and if they're not working, save your money. There are other things over the counter that you can buy. So acupressure magnets are really effective. They're called magnetic ball plasters, and you can wear them on the shamnem point of the ear, which helps sort of restore hormonal balance. Then you've got things like the lady care magnets, which I'm sure a lot of you have heard about, and they just clip inside of your pants. And again, they work at sort of trying to restore balance between the nervous system of the body, and they help bring down the adrenaline and that fight or flight response you have when you're having a hot flush. So these are things that you can purchase online. There's things.
A few things there I haven't tried, actually, so I'll make a list.
Yeah, there's lots.
I mean, we've talked about the primary stages, I suppose, of all of this, and I do want to ask whether the role of breast care nurses in terms of women with a secondary diagnosis, is that a different specialism? Is it a different team of people? How would that work?
Yeah, I mean, I can only talk for where I work, but we have a different team completely. We focus primarily on early stage breast cancer, and then obviously you do have your secondary breast care nurses or metastatic nurses, because the treatment and the support is so different, particularly the treatments. You're on a much more sort of, you never quite finish treatment once you're into this sort of a secondary diagnosis. So you're always on a sort of monitoring pathway, whereas we like to get to a certain point with early breast cancer where we can discharge you. So yeah, completely different specialisms. And I would speak for most teams, but I think there'd be specialist nurses for both.
Okay. Well, before I let you go, Charlotte, I'm also just really interested in what drew you to this specialism. I often find myself thinking that when I'm having a chat with one of the nurses at the hospital where I'm still looked after, and I'm always, they're so caring and there's such level of detail that they have to know, and I'm always fascinated by what is it that draws them to something that so often must be really tough. You see women and their families in really tough situations. I'm just fascinated what drew you to this as a role.
So we go back a few years to when I was a second year student nurse. And obviously you have lots of placements in lots of different specialities. And I was based on a breast care and gynae ward for 6 weeks. And you have the opportunity to do spoke placements or sort of day placements here and there that are linked to your area of placement. And I went over to the Nightingale Centre for a few days and worked with a nurse consultant there at the time who I was just in awe of course. And I just thought, I knew I wanted to work in oncology, just knew it. I started working hematology cancers, which doesn't always have happy endings. But then when I saw availability to come and work at the Nightingale Centre, I jumped at it and off I came. Because I think in breast care, not only are you doing a meaningful job looking after patients that are going through probably one of the most difficult times in their life, but you do get a lot of happy endings as well. And so it's just really rewarding, and you meet friends. They're not just patients, you meet friends, and that's a really sort of nice and rewarding thing to get to do on a day-to-day basis.
But Charlotte, thank you for everything you do and your team members do. I know it's a hugely important and valued job. Charlotte Milns from the Wythenshawe Hospital, thank you so much.
Thank you so much.